Good evening, everyone. This is Deepa from St. John's Research Institute. I would like to welcome you all for today's session on the basic principles of inborn errors of metabolism, organized by the Nutrition Society of India, Bangalore chapter. We are honored to have two experts in their respective fields to share their knowledge and experience with us on this important topic. The agenda for this evening's program is introduction of the speakers by Dr. Rebecca Raj. We have talk by Dr. Jalan, followed by a case study presentation by Ms. Edwina. Then we will have a short question and answer session, and then vote of thanks by Dr. Lakshmi. I would like to request all of you to please add your questions in the chat box as the sessions are going on. We will try to present all the queries to the speakers and try to answer all of them within the allotted time. We will also be sharing a link for the feedback form towards the end of the session. Request you all to please fill in the form. I now request Dr. Rebecca Raj, Professor and Head, Division of Nutrition, St. John's Research Institute, Convener, NSI Bangalore chapter, to introduce the speakers.
Thank you, Deepa. Good evening and welcome to all of you. A special welcome to Dr. Sarath Gopalan, the President, NSI. And it's indeed an honor that he has joined us. And I'm really happy, sir, that you joined us. Thank you, Doctor. It's my pleasure to introduce our two speakers. First speaker being Dr. Anil Jalan, who is a distinguished pediatrician. He founded the Nirman University, which is a Navi Bombay Institute, which specializes in genetic and metabolic aspects of neurological disorders in children. His expertise spans inborn error of metabolism, newborn screening, neurometabolic disorders, and several other conditions. He is well known in his area, and he also consults as a visiting consultant in several areas, in several hospitals such as Apollo Chennai, Apollo Belapur, is a visiting professor at SRMSC Chennai, and an adjunct professor at Manipal University. Dr. Jalan continues to provide and give pediatric health care through his dedication in research, education, and patient care. Thank you, Dr. Jalan, for agreeing to be and to take this session for us.
My pleasure, madam.
Thank you. Along with that, in order to be able to finish both their introductions together, it's my privilege to actually introduce Edwina, who is also my colleague and my student at St. John's for some time. Edwina is a renowned dietitian with years of experience, currently leading the Aster CMI Hospital in Bangalore. Her expertise covers several areas, including metabolic diets, ketogenic therapies, diabetes education, lactation, and counseling. She's also a PhD scholar, and she guides students at the university, the IGNOU University. She's certified in the nutrition management of inborn errors of metabolism by the US Commission of Dietetic Registration. Her diverse skills and her commitment to both research and community health promotion has gained her a respectable figure in the field of nutrition. Thank you both once again. And we are delighted to have these sessions, which are transdisciplinary across, having two sides, two important people in patient care, that is the doctor and the nutritionist. Over to you, Dr. Jalan.
Thank you very much. Am I audible?
Yes.
Okay, so sharing my slides. Slides visible?
Yes, they are visible. Yes, doctor.
Okay, madam. So thank you very much for the invitation. And first of all, I would like to put some disclaimers that I am not a nutrition expert. I'm just a pediatrician dealing with inborn errors of metabolism. And what I'm going to present today is perspective of a clinician. What we expect in a case of inborn error of metabolism, how we approach, what are our expectations from dietitian and from patient, because a clinician cannot really work on the diet alone. I can give some guidelines, but still the day-to-day working and patient's question has to be addressed and handled by a very good clinician. I am lucky to have Dr. Edwina, who is managing many of my patients. So let us see few things which I would go as a clinician, not as really something related to diet. So first of all, we need to understand how inborn errors of metabolism are presenting. What is the spectrum? I'm not going to deal with any biochemistry, please don't worry. Basically, what we see is cases related to carbohydrate metabolism disorder, which is glucose, fructose, lactose, and glycogen, fat metabolism disorders, dyslipidemias, and the chunk of cases which are really presented to dietitian is amino acidopathies like phenylketonuria, tyrosinemia, homocystinuria. Some organic acidemias like methylmalonic acidemia, propionic, isovaleric, urea cycle disorders, fatty acid defects, and so on and so forth. There are so many varieties. In fact, if we understand that inborn errors of metabolism is ever expanding group, the last number of disorders which we have listed is 1904. This was as late as you can say a day before yesterday. So we have this list. It's not anybody's number. It is from IEM base. This is a website. Anybody can open it. It is free. And they keep on updating new diseases as well as how to diagnose, how to manage, what all things we need to do. Everything is given in this kind of website. So even a dietitian should be aware of this kind of reference available. IEM base, BASE base. So you can download on your mobile. It is an app also, and every day or very regularly it is updated. So we have 1900. This number is old, but this is the latest, just day before yesterday. 1904 diseases, 26 group of conditions. Now, out of these, 116 are considered as treatable. When we say treatable, it does not mean that we eradicate a disease. What we mean by treatable is we manage them and we hope to get good results. Okay. So again, there is one website. This gives good details about how to manage, how to diagnose, and what all things to be done for these treatable diseases. Freely available, anybody can download it. So I'll take an example of how, as a clinician, we see a patient and where the diet comes into the picture. So before I go ahead, just a few basic slides. I don't want anybody to read these. It's a very basic slide that a dietitian also should be aware that there are some investigations which are needed in these patients of inborn error of metabolism. I'm not going to read all of them, but the most important, which I have marked in red, ammonia, lactate, blood sugar, electrolytes, and blood gases. So these are 5 important tests which most of the metabolic disorder patients will be taking, and we probably will repeat it, say once in a month or 2 months, depending on the child's condition. When I say child, I don't mean always a child. It may be newborn, it may be older child, it may be adult. Metabolic diseases can present at any age. So we should know that this is a metabolic disorder and these are 4-5 basic tests which are required. And then we have some algorithms to use for approach or diagnosis of inborn error of metabolism. Again, these are given in all the textbooks. I'm not going to read through these, but we should know that there is one algorithm available for hyperammonemia. Then you have for acidosis and high lactate, blood sugar, and all these 4 basic presentations. So ammonia, lactate, blood sugar, and ketones, or metabolic acidosis, those are the things which is presenting symptom. So many a times what happens is we see child who is very critical, very sick. That time probably diet may or may not like work. because child is so sick that we are busy with saving the life. Child may be on ventilator, but as soon as child starts showing recovery, the dietitian will come into the picture. Okay, so let us take some example. I am just taking two cases. This is the first one, 35 days old male child born out of third degree consanguineous marriage, 38 weeker, cesarean delivery, and this is a consanguineous marriage, and they have lost one previous baby with methylmalonic acidemia. So this is no surprise. Unfortunately, nobody guided them for prenatal, so they went ahead with pregnancy again. This child presented at about 10 days of age with history of vomiting, lethargy, altered sensorium, and then some kind of movement disorder, which everybody thought it is a seizure. I have not seen that child during this phase, first 1 month of life. Child was admitted in a tertiary care hospital in Mumbai. And because the diagnosis was already suspected, they started treating. And the treatment given was IV fluid and stoppage of any protein. So child was receiving some kind of formula, which was just calories without any protein. And that was going on for, say, 1 month. Now, this is something I would agree even a dietitian will not approve, but somehow this was going on, and they were told that this child is not going to survive. Why do you want to waste your money? You take this child home. So this child was discharged from the hospital with IV line so that they can give IV antibiotics. And while going, patient is from Nasik. So they started from Mumbai, and on the way is my clinic in New Bombay. And they thought, okay, let us take one opinion before we go. And child came to us. Child was in a very bad shape, very marasmic, and peeling of skin was there, some kind of skin rash around mouth and around anus. So we all know what happens in very low protein. Child was not receiving any protein and very, very bad shape. And we thought, okay, I don't know whether we can save this child, but let us try. And this is a busy slide. The initial, I just want to show you the initial part, serum protein when the child came was 3.6 and albumin was 2.3. And that was when we thought, okay, let us start some kind of protein. Luckily, mother had some milk, but not enough. So we added both, told mother to try whatever she can, but give some formula. And slowly, child's general condition improved. We did genetics to confirm that this is a methylmalonic acidemia as it was thought. Previous child had only biochemical diagnosis. So as we all know, there are so many types of methylmalonic acidemia, and we want to really confirm what variety we are dealing with. So this turned out to be mutase 0. So if you see the first picture, this was after discharge when they went home. Baby was very small, and initially when they came, they didn't allow us to take picture because child's skin was peeling and was really looking ghastly. But after a few days, general condition improved. Child started gaining weight. And this is the child for whom prognosis was given that this child is not going to survive or child will be totally retarded. Why do you want to waste money on this child? So this is, I think, more than 10 years old. Now this child is 10 or 11 years, going to school, very intelligent, absolutely no problem, no cardiac issue, no renal issue, no neurological issue. Physically fit, 45 kg, 10 or 11 years, and brilliant child. And we did regular follow-up. Parents were very motivated. So the point here is, first one, that even if it is metabolic disorder, we should not give only IV fluid or only low protein or zero protein diet. There has to be some kind of protein provided. If breast milk is available, that is best. If not available, you need to calculate and provide some protein, and we will come to that. So treatment is low protein, high calorie diet, and special organic acid formulas are available. Luckily for this case, parents were quite motivated. So initially they imported from Germany, but later on it was made available even in India. So now they are using Indian formula. Injection B12 is required, which they take very religiously. Carnitine, biotin, bicarbonate supplementation. So biochemical and whatever metabolic treatment is there that we are doing. But additionally, what is required is a very good diet. And this diet, I'll come to that, what we do, is aimed at improving general condition and then reducing methylmalonic acidemia. See, we know it is low protein diet, does not mean we have to give zero protein diet. So what I always recommend as a clinician, that you can give low protein or zero protein for say 48 hours or max 72 hours. But after that, we have to introduce. So whenever we have a real sick baby, we give them a chart that, okay, first 2 days, zero protein, and then maybe add 2 ml of EBM and then slowly increase it so that we don't go into this kind of phase. So aims of treatment are like to restrict toxic compounds, because in MMA, we know it is methionine, threonine, valine, isoleucine. So we restrict these amino acids. Enhance elimination of toxic compound that we do by supplementation of carnitine, or if child is bad, we use dialysis. That is really very helpful. And even in cases of organic acidemias, urea cycle defect, dialysis does play a role. So if you feel child is really sick and at this stage we cannot introduce a good diet, first try to get rid of these toxic compounds and use dialysis, whichever method is available. We will not discuss the types, but easily peritoneal dialysis is available. Hemodialysis is not easily available. In Bangalore, it is available, fantastic. But I have seen a lot of complications with hemodialysis. So if you have a good team who can manage, go for it. But if not, peritoneal dialysis is a safe option. May not be very aggressive, may not be very fast, but it does work. Prevent decompensation, which is very important, especially during illness or vaccination. Adequate nutrition in acute phase and long-term phase, and detect and manage complications. This is very important, especially in cases of organic acidemias, where we expect some kind of renal or cardiac or neurological complications. So we almost ask them to come once in a 3 months or 2 months for regular follow-up. And if it is done, we get excellent results. So I'll not be talking. Yeah. Now let us see. When we say methylmalonic acidemia, it belongs to a group of what we call organic acidemias. There are 18 major organic acidemias. I am taking methylmalonic as one type. Okay, in that also we have many types now. So propionic, methylmalonic, azovaleric, these are three, I would say, commonest condition presenting almost similarly. And the need for special formula is there for most of the patients. So what we do is give natural protein as well as special formula. And this is a chart. If anybody wants to read and remember, it is fine. But the amount of protein that is given is generally restricted. I'm sure dietitians will have their own way of calculating, but as a clinician, we calculate roughly. For propionic, we give little more restriction, 1.5 gram per kg. But again, it depends on the general condition. If child is doing well, we can always relax. If child is not doing well or in acute phase, we may reduce it further, but not less than 0.75 gram per kg. If it is methylmalonic acidemia, we try to find out whether it is responsive or non-responsive. Most of the cases are non-responsive in our country. So what we do is we restrict to almost same as propionic, but maybe slightly more relaxed. So 1.5 to 1.7, 1.8 we can do. In B12 responsive, we can go up to 2 or 2.5. Again, it depends on the levels of methylmalonic acid. Isoleric acidemia is much better in this group. Many of them are doing well with good amount of natural protein, and the need for special formula is really less. When we have such a patient with very severe restriction of protein, we see a lot of problems. One is this poor weight gain, poor growth, poor wound healing, skin lesions, especially because of the deficiency of branch and amino acids, anemia, osteopenia, all those things will appear. This is another baby, not the same one. But if you see, you have this kind of boggy cheeks and skin rashes. And this child also had perianal excoriation. Treated with, this is a child with citrullinemia. And the same problem, somebody suggested, okay, because it is urea cycle, let us not give any protein. But that's the problem. Luckily, mother had some amount of breast milk, so we asked her to start feeding. And then after 1 week, we introduced normal this thing formula. This child is also now, I think, 10 or 12 years. And he underwent liver transplant and is absolutely fantastic. He is now in school, intellectually normal, physically normal, very good height and weight. So we can achieve good results. You see this kind of excoriation is seen. This is another child. Unfortunately, we lost this child. This was just 2 days before his death. They brought this child with this kind of peeling of skin. And I am always scared if I see this. I tell my people that it's almost terminal. You act fast, otherwise we are losing this child. We have lost couple of patients like this. So please remember, this is one sign which is really scary for a clinician. And this just means that we have done over restriction of protein and given mostly calories. This child was only on dates and some kind of grape juice or something, and hardly any calories, hardly any protein. Okay. So it is again nowadays little bit controversial. Some countries prefer using special formula right from day one without seeing the need. They always suggest, yes, you must use a special formula. Whereas Australia is really not in favor of using special formulas. They prefer using natural protein and EBM or breast milk. And if necessary at all, they may use a very small quantity. So there is one beautiful paper from this lady, and it was presented in SSIM conference. And what she presented is the need is there in 91% cases of propionic acidemia, 62% of methylmalonic, which are B12 responsive. That is what we see in our country. They will need, which also means 38% will not need. Okay. So 1/3 cases will not need special formula. They can be managed with natural protein. If you see B12 responsive, only 1/3 or 1/4 cases, 23% cases will need special formula. Others probably will not need. And isovaleric acidemia 50-50, probably 54% as per their calculation. But in our experience also, we have many patients with isovaleric acidemia. And they are doing very well with just protein restriction without any special formula, especially when they grow old, around 5 or 6 years. They really don't want to take these formulas. We'll come to that. That's a big issue in our country now. But if we can omit special formulas, medical food, what we say, then children are much happier. So just remember, there are some cases where we can manage without medical formulas or special formulas. And we should give a try if child is doing well. If child is sick, please don't try. Okay, you all know, I need not tell you about special formulas. There are two types. One is formula type, one is just amino acid mix type. So I personally prefer formulas for young children, and for older children or adults, we can use concentrated amino acid mix. Unfortunately, what we get here in India, my experience is quite bad. Most of the children don't take it. They don't like, because it's very nauseating, smell is bad, taste is bad, and children really don't take. So if possible, I suggest them to get from some international brand. But if cost is an issue, of course, we don't have any other alternative but to go for Indian ones. Edwina is trying to make some changes. She suggests, okay, mix this, mix that, some kind of modification, and to improve the palatability. But It's like a bitter gourd. Whatever you do, the basic taste does not change. So that is our limitation. So we will not be discussing that. Okay. So when we have organic acidemia, today we are talking about organic acidemia. We have to look at the calories. They need more calories. Generally, I suggest at least 20% more calories, but avoid giving too much calories. We don't want any overweight child. If possible, use breast milk. That I say is a lifeline for any child. There are only few conditions where we don't recommend breast milk, but most of the inborn errors of metabolism, I say, will require breast milk. And I really urge pediatricians and gynecologists not to give any injection to mother to stop breast milk production. So this is something which is really a lifeline. We have saved many, many patients with this. Many of them, organic acidemia, especially propionic acidemia, they will have anorexia and they don't eat properly or they don't drink this formula. So in that case, probably you will have to use tube feeding or maybe gastrostomy. And you can use some kind of weaning like small amounts of fruit juices, vegetable soup, and things like that. But after your protein requirement is filled up. Okay. So protein requirement, we calculate this calculations again, you are more experienced and dietitians, I don't have to tell them. But roughly, we take this kind of calculation in our account that, okay, we give this much protein and there should be some amount of branch and amino acid available. It's not totally free. You see, if you have a patient of organic acidemia, and I know I don't want to give methionine, threonine, valine, isoleucine, but I cannot keep child on zero valine, zero threonine, zero methionine. So we use this range, maybe around, say, leucine I take into calculation and then either methionine or one of these. So that tells me how things are going. And we try to keep it on the lower side, but still it is required. So you need to give, you cannot make it zero. So what we do or what we suggest is you calculate protein requirement and roughly 50% I would say we provide 50% from natural sources, 50% from special medical formula. You need to avoid this propiogenic amino acid, that is methionine, threonine, valine, isoleucine. So you need a special formula. You cannot make this with Indian diets or regular natural food. Many of the parents say, no, we don't want to give any artificial formula. You tell us which food will have these amino acids zero. There is no such food. At least I don't know. If you know, you tell me. But what we do is general protein restriction and then add these formulas to make up for the protein loss, whatever we want to give. And you people are expert in calculating, but to parents, I tell them roughly, okay, you give 50% from natural sources, 50% from this special formula, and depending on child's appetite or child's intake, you play with that. You can increase or decrease little bit. Some children take special formulas easily, some children don't take. And we try to maintain calories concentration, say 1 kilocalories per ml of the formula for young babies. While doing this, we of course suggest a regular monitoring. This is absolutely important. Unfortunately, I have seen many patients, once they get this prescription from a dietitian, I have many cases on my record. They continue it for years together without bothering to do any follow-up studies, without bothering to ask dietitian, okay, now should we change? Child has grown up, the weight is different, the requirement is different. They just keep on doing the same thing. So please give them prescription saying that this is valid only for 1 month or 2 months. And then we need to follow up. You get clearance from a clinician that child is okay in a good anabolic state. You give enough of whatever protein is required or amino acids required. If child is in a bad shape or catabolic state, you need to change. So what we do is calculate dietary intake, height, weight, and BM, this thing, uh, body mass index, and some basic studies like CBC, liver function test, renal function test, especially for methylmalonic. And then TMS, that is carnitine, acyl carnitine, amino acids, which is absolutely important. And please rely only on HPLC, not on TMS amino acids, because they are semi-quantitative. And then B12 level, vitamin D3 level, and there are few other things like serum iron, TIBC, ferritin, and maybe cystatin C in cases of methylmalonic. So there is a list of investigations, and I recommend dietitians to, because patients interact with dietitians much more than a clinician. To reach me, they have to take appointment, and that will take another 3 months. But to dietitians, they approach easily, and they have a lot of questions that this particular food child is not taking, that particular food child is not taking. I remember one patient came to me saying that my dietitian has prescribed 23 grams of banana. So which banana should I take? Now, I also could not answer this. 23 grams of banana, how somebody is going to calculate? And whether it is your regular banana or it is small elaichi banana, I had no idea. So I told them, please, you go to your dietitian. This is something very, very specific. I cannot answer, but from my point of view, if child is having organic acidemia, banana is not a problem. Whether you take 50 half gram banana or half banana or one banana doesn't matter. So that was okay. That problem was solved. What I am trying to say, whenever we prescribe, let us make it little bit more simple for common people to understand. I've seen beautiful details by Edwina and many other good nutritionists. Dr. Madhvi is there, and there are many. And ultimately, what happens is a patient has to understand how to calculate. So if she knows, okay, this is the food which I cannot give, she will not give. So we need to explain. Of course, we all do that. But I would be happy to see if it is written in their local language, or if they understand English, fantastic, or some kind of pictures. Now, one very, very important point which I want to make it here is that many such patients, they are in constant touch with dietitians, much more than a clinician. So you please note down this site. This is British Inbound Error of Metabolism group, or IMD group, and they have all emergency protocols. It is by names. So if you want, say, emergency protocol for methylmalonic acidemia, somebody may call you that my child is sick, say fructose 1,6 diphosphatase deficiency or propionic acidemia. Child has become unconscious. What should I do? My doctor is not reachable. Just click this. It is available online, free of cost. Download all the recommendations are in PDF format. So you can send it, print it, hand it over to them, that they should always carry this kind of emergency protocol wherever they go. And if a pediatrician or a clinician is there, they can just read it and follow it accordingly. So very, very simple. It is available online. You should have it on your mobile or this. So this is one example. So it gives methylmalonic acidemia, acute decompensation, what needs to be done. It is a detailed thing, 4-5 pages. And they explain why, because background is given, why we use this, why we use that. So clinician understands what is to be done and why it is to be done. Okay. So this is for emergency protocol. We should keep with you, at least in the patient's file. So just summarizing again, ensure optimal nutritional intake. Anorexia needs to be taken care. And there are many other things which are required. And if child is not taking, you need to give by tube or sometimes G button or gastrostomy. So this is one patient. This patient is not from India. They are from UK. And in UK, they prefer putting in tube. And child was taking orally also. So I was little bit surprised. But this is just to make sure that she takes medicines, which she was really not taking. After a few days staying in India, they removed the tube and child was still taking everything, and they were very happy that we could remove the tube. But we need this in organic acidemias. Sometimes propionic acidemias are very bad. They don't really have good appetite. G button or gastrostomy, we all know it is not very frequently used. Uh, in US, UK, or Europe, people are very fond of this. They just do this, and all the feeds are going through this. But if needed, yes, we can use it. I have done it for 2, 3 patients. My surgeons help me, but it's not a regular thing in India. But please remember, if it is organic acidemia, we may need. So any organic acidemia, I'm talking like organic acidemia is like 18 different organic acidemias, but propionic is one of the worst kind of organic acidemia. There are complications related to this, so we should know that there can be some problem. It's not without problem. So I am a bit skeptical, but if need be, yes, you can use. So there can be ileus, there can be peristomal infection, leakage, sometimes ulcers, but even deaths are known. One of my patient expired, so I know from that time I'm a bit scared of this. Necrotizing fasciitis, peritonitis, these are all known complications. So this is what I wanted to say about organic acidemias. And organic acidemias are really, they are quite tough to manage in the initial phases. And please remember, once they improve over a period of say 1 or 2 years, then they become a bit easy to manage. And this is the question asked by many parents, that okay, right now we can afford special formula or this kind of diet, but when child grows older, what happens? And my answer to that is, most of the time body takes over, and most of the time we really don't need that large quantity of special formulas. Sometimes we need to supplement, just like a protein or some tonic we give for a child. You think like, okay, it is a tonic, we are supporting the child, but child is on normal natural diet, and we may need it, but usually after 6 years, we are bit relaxed. Okay. So if I have time, I'll just take second case. Should I continue?
Yes, doctor, you can continue.
Okay, madam. Thank you very much. So this is baby HM, 13-month-old female child born out of non-consanguineous marriage, cried immediately, presented with history of developmental delay, dystonia, hypopigmentation, and hypotonia. I'm sure now everybody must have guessed what it is. There were no seizures, no dysmorphism, normal hearing and vision. And child had TMS report which showed phenylalanine, sorry, that is missing here, phenylalanine of 1200 micromoles per liter. So genetic diagnosis was done, and it confirmed PAH, phenylalanine hydroxylase deficiency, that is the classical phenylketonuria. Now, as I said, the most important part of managing any metabolic disorder is a regular follow-up. If patient is not interested in follow-up, then there is no point in suggesting diets or suggesting liver transplant or anything, because sometimes some people have this kind of thinking, okay, this one child is affected, I cannot destroy my family, we have limited funds, so we will have another child who is a normal child. Then I have nothing to say. But if they are interested, then only we take care of these kind of patients. And I have at least 30 cases of phenylketonuria, those who are following up with us. Okay, so if you see the levels of phenylalanine, initially when it started was 1113, okay, and the tyrosine was low. Now in PKU, I'm not going to discuss the clinical aspects or the biochemistry. From dietitian's point of view, the most important part is phenylalanine and tyrosine. Just pay attention to these two figures and preferably use amino acids by HPLC. TMS gives some values and they are okay to screen, which means 1 time or 2 times you can use it as a screening procedure. But when you want to follow up, The best method is HPLC, and that gives really quantitative values. Okay, so let us see what is happening in this child. So initially, for almost, I think, 1 year, we used regular phenylalanine-free formula and restricted diet. Unfortunately, in PKU, what happens is your need for special formula is much high. Normal diets, you can give protein about 25%, but 75% you need from special formula. It's not like organic acidemia where we think 50-50 is okay to start with. Here, we prefer to start with much higher doses of special formula. We did that here. Child was taking, and we could achieve some kind of improvement. Initially, if you see, it was 1100, then 1000, then came to 600. But now child is growing older, and now she is refusing to take this formula. So slowly, parents also felt, okay, now child is fine. Why we should continue this much? So they reduced a special formula and increased normal diet, like normal protein. Patient is from Kerala, so and Muslim family, so they are very fond of non-vegetarian food. I don't know whether this child is taking. I doubt she must be taking, but parents say no, she's not taking. But we realize that her behavior, her neurological condition is not good. She was quite delayed, and she had a lot of behavioral issues. No seizures. So when it started increasing, that time I gave them option that, okay, there is something else available, which is called long neutral amino acids. And should we try that? Generally, it is not used in children, but in some cases we use it. And I discussed this with Dr. Rani Singh. I don't know whether she's here on this particular group. And what she said, there is no contraindication, but just don't use it as alone treatment. Don't use only long neutral amino acid. You need to mix with or you use along with your special formula. Okay, fine. So we started that. And after that, there was remarkable improvement, not only in the phenylalanine level, but in the behavior. Child was doing fantastic. Like when she came after a few months, when these levels came around 600 and 400, she was like absolutely a normal child. She was smiling, giving shake hand, sitting properly in a chair. I'll show you her picture. And they were so happy that she is totally changed, totally changed. So this is something which I suggest to all the dietitians to keep in mind that if you have a patient, any age, you can use this long neutral amino acids. So when we start treatment of phenylketonuria, what we do is generally for 2-3 days, we don't give any protein containing feed, just to give washout. Now there are recommendations. Every time we don't follow this, but in general, what we say, okay, 2 days you don't give, then we can start. But if you want to follow, there are standard recommendations, and for different kind of levels, we have different washout period suggested. So you can use this, but roughly I say 2 days is good enough, 2 or 3 days. No harm. 1 day extra doesn't make child sick. So that is fine. Then after that, what we do is the amount of phenylalanine. See, we cannot give totally phenylalanine free formula. So child cannot be only on formula. Child needs some amount of phenylalanine, or rather some amount of protein. And when we calculate phenylalanine from this protein which child is taking, so you have some kind of prescribed phenylalanine which is allowed. I generally go by protein calculation rather than by phenylalanine calculation. But I always ask my dietitians if you can calculate phenylalanine from that and give me a hint that whether she is going overboard, she or he, we can control that. So this is what is recommended. You can use this. And different formulas will have different kind of phenylalanine tyrosine. So if you see normal infant formula, I'm not talking about phenylalanine free formula. This is a normal regular infant formula versus breast milk. Now see the advantage of breast milk here. You have at least 25% less phenylalanine. and it has almost equivalent amount of tyrosine. We are interested in tyrosine. Tyrosine is important for neurotransmitters, and I'll come to that how we supplement tyrosine. So the total protein of breast milk is lower than the formula, but calories are almost equal. So this always gives us a good chance of helping a child. And in any PKU patient or even MSUD patient, I suggest breast milk should be used. Okay, so now we have different recommendations for amount of phenylalanine which can be given or amount of tyrosine which can be given. Problem is, if we start calculating and start prescribing, it becomes little difficult. At least for Indian patients, I have seen that whatever we prescribe, they don't take. But calculation is important, so it helps us in understanding what is going on. So this is what we recommend for the particular ages 0 to 3, 3 to 6, 6 to 9, 9 to 12. Look at the tyrosine intake. This is what I am trying to highlight, that we need more tyrosine. So pay attention to tyrosine. When you are calculating phenylalanine is low, I know, but the tyrosine has to be in a good range, really good range. And then the ratio of phenylalanine to tyrosine, what we see in parents, in plasma. Now coming to this long neutral amino acid business, we all know that long neutral amino acids are transported in the brain by one transporter, which is called LAT1. And if you have phenylalanine, that is always preferred. So it will suppress other long neutral amino acids, and tyrosine is one of them, which is very important for neurotransmitters. So if you have neurotransmitters deficiency, that means deficient dopamine, deficient serotonin, child will have a lot of behavioral issues. Now, this is happening because the phenylalanine is high in circulation, and that is really having competitive inhibition to tyrosine and other things. So when we give high tyrosine, the phenylalanine is suppressed, and that goes in circulation or in the brain, and you get much better tyrosine levels, and which also gives you much better serotonin and dopamine. So pushing this in brain. At the same time, some amino acids, not only tyrosine, but some other amino acids, especially leucine and threonine, they will inhibit absorption of phenylalanine from gut. So when you give long neutral amino acids, we are doing two things. We are reducing intake of or absorption of phenylalanine, which is almost to the tune of 39 to 40%. And we are also providing brain with enough amount of tyrosine and tryptophan and reducing phenylalanine intake in the brain. So you achieve two things, one stone and two birds, like that. So we get very good neurotransmitters and also reduced phenylalanine. So this is what we want to achieve. Long neutral amino acids are available both abroad and India. This is what is available from international market. Composition, if you see, one tablet will give tyrosine of 250 milligrams, tryptophan of 250, and there are a few others. Whereas if you see Indian one, which is quite high in tyrosine, but not so much in tryptophan, anyway, it doesn't matter. There are many other amino acids provided, and they are in the range of 30 to 40 or 50. So how to give? Long neutral amino acid is calculated for children as 30% of your protein requirement. So if you have a child, you have calculated say 10 grams of protein per day. Of that, 30 or 35% you can use by long neutral amino acid. Another whatever remains from that 30-35% you can give by special formula, and then remaining by natural. If it is an adult or adolescent, you can use only natural plus long neutral amino acids. So they may not take special formulas. And that is the reason why long neutral amino acid is introduced in adults, because they are not really happy taking these kind of formulas. So long neutral amino acid being a tablet, it is very easy. They just pop tablets and they feel, okay, I have taken some medicine. and they take natural, normal food, and this is given after food. Always remember, please, because it is going to inhibit absorption in the gut. So giving it any time randomly is not going to help. So give it after food. Calculate for children about 30% roughly. And Pristine Organics is manufacturing this. It's available in the granular form, not as a tablet form. But internationally, tablet form is available, which is of very high quality but very high cost also. So about 50,000 or 70,000 rupees for a bottle, which lasts for only 1 month or maybe less. So I have a couple of other patients, and after study, red arrows suggest where we started long neutral amino acid. And after that, if you see consistently, we get very good ratio. We are interested in phenylalanine to tyrosine ratio, if you see. So there is good improvement in phenylalanine to tyrosine ratio and child's behavior. One of the child, I think some 4-5 years age, maybe, he has a lot of seizures and treated with 4 or 5 anticonvulsants. But after starting this, his seizures almost disappeared. He is only on one anticonvulsant, which also probably doctor will reduce it. He is seen by Dr. Suresh Rao Arur, a very senior neurologist from Bangalore. A child is doing much better after long neutral amino acids, especially for seizure part. So this is that first child which I was showing you. Initially, if you see the hair, hypopigmented, fuzzy hair, and now she has much better. Initially, she had hypotonia. She was not able to stand. Mother is supporting. But now she is doing absolutely fine. Sitting properly, talking. She's giving flying kisses and everything. Like any other normal child, she does. Here also in phenylketonuria, we need regular monitoring. The only thing which we additionally do in phenylalanine or PKU patients sometimes is taurine levels, that is PTERIN, taurines, urine, or sometimes CSF also. And folinic acid is given because 5-MTHF is also low. So these are the few additional things, but regular, whatever we do for any organic acidemia, similar kind of approach, low protein diets, provide sufficient calories, sufficient micronutrients, like that. Breastfeeding, I have been insisting, and sometimes this gives little problem because parents have been told that this child is sick and has metabolic disorder. Don't give breast milk, and mother is so depressed that either she breaks down or she loses all the milk. So from beginning, I think if you have a diagnosis of these kind of conditions, tell them that we will be using, and just be hopeful that within few days we will start. So there are advantages, we all know. Where we should not use breast milk, only 4 conditions: galactosemia. Sometimes now we use for VLCAT, but it is a decision of clinician. I think here dietitian should not suggest, because we have lost patients. They develop arrhythmias because of this fatty acid problem. So please discuss with your clinician whether we can give breast milk. Some amount can be given, but child cannot be on totally breast milk. We have to give special formulas here. A-beta lipoproteinemia, hyperchylomicronemia, these are the cases which are quite rare. We don't see it very often. But if it is there, we give a totally fat-free kind of milk. There are cases which are managed: PKU, tyrosinemia, all organic acidemias, including glutaric aciduria, urea cycle defects, homocystinuria. Protein contents are low, but initial colostrum is high. So as I said, if you diagnose, initially 1 or 2 days we don't give, and then we start giving. So that probably we can manage. This is one old paper. I think it's, 2006. And there are records that PKU, 160 patients have been managed, and tyrosinemia. I think Anita MacDonald, everybody must be knowing. Dietitians must know her. She's a very good dietitian from UK, like Rani Singh. And there are many lectures available online. So Anita MacDonald has done a beautiful work in this, breast milk in inborn errors. And this is the paper, if anybody is interested, should read. Journal of Inherited Metabolic Disorders. just last few slides, why we are insisting on treatment. See, many times we feel that I'm treating, I think this is experience of all the dietitians, especially some cases say of phenylketonuria or homocystinuria or cystinosis or you name it and we have it. That we are treating, child is taking diet, but there is no neurological improvement. And why is that? The reason is these amino acids, when it is in more than physiological level, they form amyloid-like structure. It does not remain as a soluble amino acid in plasma. They go and sit in brain and nervous tissue. And there are papers, beautiful papers. We have no time for biochemistry discussion. But what they do is these amyloids are like structure. They go and sit in the brain. They damage DNA. They damage RNA. There are apoptosis. Now, if you see, this is a beautiful electron microscopy, I think. Yeah. So it shows methionine fibers and cysteine fibers. What happens? They don't remain soluble. And once this is formed, you cannot undo it. This will still remain in the brain. So what we are treating is trying to reduce amino acid is only in the blood or in the plasma. In brain, it is still amyloid structure, which is damaging DNA, damaging RNA, as well as it forms large plaques on the brain. I'll show you picture. See what it's like huge. It's a crystalline structure, but now you cannot break it. There is no way we can break it. This will sit in the brain, and that is why these patients don't improve, whatever you do. So the point is, if you want to get good results, you have to start very early. How much time we get? Once it is elevated, especially in the newborn period, you get 15 days. These are the experiments done. So within 15 days, if you start treating, you get good results because now amyloid structure has not formed yet. And all the amino acids are in circulation in soluble form. You can reduce it, you can improve it, and child will do much better than if you start treating at the age of 4 or 5 years. So newborn screening becomes very important. But this kind of amyloid structure is really a problem. That's why we don't see that kind of improvement that we expect. So start early, and treat aggressively. This is a good paper if anybody is interested. People have done a lot of studies in this amyloid structure. So this is how it damages RNA and DNA. Okay, so thank you very much. This was my, as a clinician's approach or clinician's view. Just couple of points, like whenever we suspect metabolic disease, we have this plan. And initially 2 days or 3 days, we will give without any protein, treat emergency, whatever is there. And once we start treating, slowly improve natural protein also. So initially, yes, we need special formulas, but along with special formula, if it is a small baby, infant, insist on breast milk, if it is allowed. If not, of course, formulas are available. You can use that. Judiciously increase it. Monitor regularly. This is absolutely important. I was trained in Germany. Unfortunately, here that kind of system is not followed because their government is paying, your patient has to pay. So there we used to do once in a week, once in 10 days. All these PKU patients, organic acidemia patients, they get all the tests done initially once in a week to once in a month. And then slowly it is come down to like once in 3 months and then once in 6 months. After 2 years, you can relax and maybe once in, say, 6 months is okay, but not later than that. Thank you very much. I think we will be taking questions at the end, right?
Yes, Dr. Jalan, if you don't mind, we'll finish with
Absolutely,
Mrs. Edwina,
absolutely.
and then
Yeah.
we'll do combined set of questions.
Yeah.
Thanks again.
Thank you. Yeah.
Over to you, Edwina.
Thank you,
Yes,
ma'am.
maybe.
Thank you, sir. That was well illustrated, and no wonder there are maximum participants and they've exceeded the limit. Many are even messaging that they would want to join. Okay, so I'll just screen share. Sir, if you can stop screen share.
Yeah. I'm just trying to do that. I did that. It's
Okay. Fine.
still seen? No.
No, sir.
No. I think it's moving on to Edwina's.
Is my screen visible, ma'am?
Yes, Edwina.
Yes, Edwina, it's visible.
Thank you so much. So at the outset, it's my privilege to share this platform with Dr. Jalan. I would like to thank him for agreeing to give this talk. And along with this, I should not be forgetting Rebecca, ma'am, who has given me this opportunity, and all the NSI committee members who insisted that I should do a case study. I'm again privileged to speak, talk about the case study which I've practiced along with Sir. So before all the stalwarts of nutrition here. So to begin with my case study, this is about glutaric aciduria type 1. So we see many of them have been asking how to, they've been appreciating the session. So we of late, we haven't seen more of IEM cases being discussed. So it is very difficult to cut short this entire ocean of knowledge to just make it very short. So to start with my case study, this is about GA1. This is my disclosure. So the background, I've picked up a child who came to us, 11-month-old female infant, through a video consultation from Madhya Pradesh. So this was referred by Dr. Jalan. So earlier they were seeing a doctor in Madhya Pradesh itself. So when this baby came to us, the length was recorded, weight was recorded, but unfortunately we didn't get head circumference. Length was 73 centimeters, which was at 50th centile, and weight was 5.1 kilos. And you can see the extensity of malnutrition where the centile was below third, in fact, and it was underweight. So birth weight was 2.75 and this baby was full term. The diagnosis was made when the baby was 6 months old. It was glutaric acidemia, and there was severe dystonia as well as seizure. So we could clearly note the weight. There was poor weight gain, as well as most of these kids, they suffer from constipation. That's pretty common. I'm sure all of you agree with me. So when we looked at labs, so these are not made up numbers. This I've taken from the case report itself. And you can see the plasma amino acid level here. The lysine levels had drastically dropped. It was 19. Basically, the minimum level was 116. So apart from that, even tryptophan was extremely low. It was hardly 1. The minimum value was 10. And the report says that this appears to be secondary to protein deficiency. Even in the previous presentation, Sir was repeatedly mentioning that we severely try to restrict protein. So probably that was one of the reasons in this case. So we will look at it, how it happened. So along with this, we also looked at the total protein where it was 5 and albumin was 3.1. So both were extremely low, and the branch chain amino acids were also downtrending. So albumin level we considered because it was not in acute phase or in infection phase. The baby was not hospitalized. So we have considered this value as well. Then considered the history of the patient, where we saw in terms of development, there was good social smile. And but in this case, baby was crying, irritable, it was unable to sleep, the neck control was poor. And as mentioned earlier, there was severe dystonia. Dystonia is a kind of involuntary contraction of muscle, and that is seen and it leads to movement disorder basically. So to treat dystonia, the doctor had prescribed muscle relaxant, and because of seizure, medicines were given, anti-reflux medication, as well as carnitine was prescribed. I think this was slightly higher because carnitine requirement is 100 mg per kg per day. So this was exceeding. Why carnitine? It is because to remove the excess toxic compounds, especially in organic acidureas. And riboflavin was given. But there is no, I will come to this later, and arginine as well. This is to treat the developmental delay and cognitive problems. So, and vitamin D3, unlike any other child, this was prescribed. So if we consider the diet history, volume exceeded, in fact, it was 1060 ml fluid. Why? Because the medical formula that was prescribed was almost 12 scoops. And to remind you about the weight of the infant, it was 5.1 kg. So what was given? Breastfeeding was stopped at 6 months. My mother complained of poor secretion. Later on, the baby was given only rice, carbohydrate enriched foods. So it could be rice flour, arrowroot, potato mash, and vegetable and fruit puree. Only this was prescribed. And when we looked at medical formula, how much it gave when it comes to 6 scoops in terms of nutrient value, it was around 463 calories, protein was 14, and fat 24, and so on. Then complementary feed was given only 250 calories, and through complementary feed, protein intake was hardly 2 grams. And Sir had mentioned, Sir was mentioning earlier, so at least 50% should be from natural sources in cases of GA1 at least. And total intake came up to 140 kilocalorie per kg body weight and 3.1 gram per kg. Though the calorie intake, protein intake was pretty high, still we did not see any improvement in terms of weight. And fat and carb percentage was pretty decent, but the lysine, what the baby was taking earlier, was hardly 160 mg per day, which is at around 31 mg per kg per day. The actual guidelines recommend about 90 mg. So this is how the baby looked. The nutrition-focused physical examination included severe necrotizing dermatitis on hands and legs, and even the hair was thinning down, and muscle wasting, we could see irritability, fatigue. So when we did the nutrition diagnosis, STAMP screening tool was applied and the scoring was high. It was about 6. It was a high-risk case. And SGNA, when we looked at it, it was severely malnourished. And problem etiology, signs and symptoms, if we have to state, then we could make out that there is poor intake of intact protein through natural sources. And it is related to prolonged adherence to lysine-restricted diet. Basically, there was no guidance properly given. There was no calculation made, and no no guidance taken from any metabolic team. It was evidenced by muscle wasting, poor weight gain. There was scanty hair growth, and you can see in this picture, there's necrotizing dermatitis both on hands and legs. So just to give you an overview about the glutaric acidemia type 1. So when we consume proteins, basically, we all know it gets converted into amino acids. The end product is that. And then the tryptophan and lysine, it is further converted into glutaric acid. The enzyme which is responsible, that glutaryl-CoA dehydrogenase enzyme, which helps to give out the energy and helps in growth and development. In case of glutaric acidemia type 1, this enzyme is not present. That's the reason there is buildup of glutaric acid and harmful substances. That is the reason we can see in this condition, if it is not treated at birth, if it is not picked up through newborn screening, later we can see severe symptoms like macrocephaly, there is enlarged head circumference, there's seizure, ataxia, chorioathetosis. This is nothing but involuntary movement of fingers as well as toes. And then there is episodic vomiting. The child can end up in intermittent metabolic acidosis. Ammonia levels can go high. and frequent hospitalization can occur. And most of these patients, GA1, what we see is that length is not a concern. Their height development is absolutely great, but weight would be poor, as well as we see severe dystonia in them if it is not properly treated, and neurological damage can occur in such cases. So diet, focusing on diet is quite imperative. As early as possible, we should insist the baby takes low lysine diet. When we give low lysine diet, obviously we'll have to supplement it with other amino acids, which are lysine free. And in our country, we have tryptophan reduced as well as a tryptophan free formula. So based on that, both are absolutely fine. We can recommend any of them. And then the goal is basically to maintain the lysine levels and then tryptophan at normal range, as well as to supplement with L-carnitine, which is about 100 mg per kg. Riboflavin, there's no clear-cut protocol, as well as L-arginine. Even the training where I underwent, and even according to the guidelines recommended, it is not necessary that it needs to be prescribed, because L-arginine can come through, we can source it through medical food itself. It's already present. And as Sir mentioned, plan B for emergency treatment should always be there in place. And we should be ready to advise them in cases of an emergency. So here you can see the guidelines about lysine recommendation, at what age we will have to recommend how much of lysine. In this, you can see the special amino acid formula through which we will have to give about 0.8 to 1 gram. In this case, in this case study, basically, I'm focusing. And by age, if you have to look at glutaric acidemia type 1, there are guidelines wherein you can see how much of lysine, tryptophan, protein, energy, fluid requirement. Unfortunately, we don't have Indian guidelines. That is way forward. We will have to create Indian guidelines because the cases are increasing. It is need of the hour that we need to have this in place. So how about the nutrition intervention? If we look at the intervention part of it, I'm just trying to compare here the pre-intervention phase and phase 1, that is the intervention phase. So here, if you look at the total calories, what was prescribed earlier was pretty high. Even the protein recommendation was high, but most of it was coming through medical formula. And the absorption, what we have been seeing even in the literature as well as the guidelines provided, there is less absorption of protein from medical formula, as well as it is not recommended to give entire protein source in case of GA1 only through medical formula. Rather, we should equally supplement with natural source of protein from complementary feed in this case. So we brought down the medical formula to 5 scoops, and then we gave protein-free carb-enriched formula, yielding some calories without protein. And complementary feed, we could fetch some 7 grams of protein, that is at around 1.3 gram per kg. Finally, we came up to 127 kilocalorie per kg, and protein was 2.5. Fat percentage and carbohydrate intake was optimized. And then lysine, earlier it was 31 mg, then later we optimized it to 90 mg per kg per day. And even the fluid requirement as per the guidelines was given, not exceeding the limit also. So menu planning, since the baby was from MP, as Sir was mentioning, it should be more practical for them. We have to give them more recipe. So most of it was poha and all their local foods that they use, as well as some foods that we can introduce, which is low in lysine, as well as the some which are lysine free should also be focused. So when it comes to exchange list, this is how I've calculated. The total lysine was 460 mg. So that each exchange is about 25 mg. So about 18.4 exchanges would come. That I have distributed among all the food groups. And here, most importantly, we have added dairy. We have included milk or curd in this baby's diet. So it was around hardly 60 ml. And which gave about 172 mg of lysine. So even in this case, as sir was mentioning, protein intake is crucial. So that's the reason protein intake from biological value, a good source of protein, was quite imperative in this case, basically. And we suggested some coconut intake, about 15 grams, which was low in lysine. How much to give, and they since they are from MP, they didn't wanted coconut, so we had to switch to peanut. So the amount was given. In this case, we have to calculate in terms of recipes and mg how much of lysine comes through each recipe, so that it is more precise, and we work carefully because we should not exceed the lysine limit also in this condition. So to summarize, the case was discussed with the metabolic consultant because a multidisciplinary approach is important, a neuropediatric as well as this metabolic consultant. We should take their opinion, and along with that, multivitamin were prescribed, calcium, vitamin D, zinc supplements, and L-carnitine was optimized, protein intake up to 1.3 gram per kg, and then the medical formula through that 1 gram per kg was recommended, and fluid intake was adjusted, and even the calories were optimized, distribution of carb, fat, protein up to 127 calories per kg, and then the lysine intake was calculated up to 90 mg per kg. Then we provided about 25 mg of lysine food exchange list. As they progress furthermore, as the patient comes for follow-up, it is important for us to give them a lysine food exchange list so that they do the calculation by themselves, so that we train the mother, and we need to insist that they have to maintain a food diary, and every quarterly they will have to, initially we need at least weekly follow-ups, and then quarterly they need to follow up with the dietitian, and some recipe links are also necessary. So some lysine free flours or cookies or some supplements specific to lysine free formula we needs to be suggested, and it's all available. I'm sure all of you are aware. So monitoring in GAK's analysis is important. As mentioned, growth monitoring. If it is adults, BMI and BCA is necessary, and amino acids, we have to optimize carnitine supplements, micronutrient supplements, as well as if needed, fatty acid supplements. All these are necessary. And then provide a lysine exchange list for self-management, about 25 mg list, and it is easy and simple for them to do the recipe calculation, to give some, to add some changes, to tweak the recipes, and to give something according to their preference and their local foods. And later on, as they progress further, and when the child becomes older, we can give just the protein count. That would be much easier for them. So DEXA is only after 8 years, we will have to monitor. So we could see the improvement in this child, basically weight when she was 11 months, 5.1, and up to when she came up to 20 months, she improved and came up to 8.2. And I'm glad to share that we have presented the abstract at Jerusalem last year. Sir has presented this. He was the only speaker who was called to speak in SSIEM conference last year. So he's presented this abstract. So this you can see later how the baby improved. The dermatitis and the lesions completely disappeared in 8 weeks' time. So now she's absolutely doing good. In conclusion, I would say combination of special medical formula and natural sources are quite important in GA1 cases. And maybe some, in certain cases, we will have to add high biological value protein and then taper it down whenever not needed based on the quarterly plasma amino acid value. So we need to work closely with the metabolic consultant and understand how we need to tweak and change the requirement. So treatment of malnutrition is it is equally important. How the levels needs to be maintained. At the same time, we have seen off late lot of cases with protein deficiency, as mentioned, right, sir rightly said that we just give only carbohydrate enriched. We just follow the emergency treatment protocol, and later, and even those parents don't come back. That's when always sir tells that they are like bubble. We don't know what happens. They are at high risk of mortality, IEM cases. So we need to closely monitor with a collaborative team. Thank you for your patient hearing. These are my key references. It's easily available through GMDI guidelines you can get, or SSIEM. You can also look up for some courses on IEM. So it's need of the hour that all of us should be well trained and prepared and gear up, because the cases are increasing. Thank you so much. Thank you for your patient hearing. I think I've exceeded the time limit. If I've done, I'm sorry about that. I'm happy to
No,
take questions.
no
Thank you, ma'am.
problem. Thank you. Thank you so much, Dr. Jalan and Edwina. That was a wonderful presentation and your insightful thoughts actually. And if you will notice and if you will see in the chat, the constant praise is practical session, practical session, practical. And total appreciation, Dr. Jalan, for you and for
Thank you,
Edwina.
madam.
And I'll happy to open and I will read out some questions that are there in the chat box so that you can actually answer them. I think I will try to direct who it is for, but I think maybe some questions either one of you can answer. So as I said, the main ones were the praises for you, saying extremely practical guidance and presentation. One of them wanted to know if you have any nutritional guideline resource for the various IEM. If I think more India related, they are asking. You did present the BIM DJ. So is there anything that is more related to India?
No, madam. Unfortunately, right now, even for international, if you see, they give basic guidelines. Okay, this is like you avoid this amino acid or this particular protein or whatever, but they really don't talk about how you achieve that. And many a times what happens, a clinician, especially the young ones, they just read in the textbooks. Nelson says, okay, don't give these amino acids, and they give only fluids or some kind of calorie supplementation like calolipid, maxijoule, or whatever is available. And there we have problems. So what happened, we produced one small booklet. It's not really a big book, on diagnosis and management of inborn errors of metabolism. This is done by, I think, ICMR. And it is sort of algorithms and protocols. And there we have mention of diet also. So it is not only diet, it is for clinicians for diagnosing and managing inborn error of metabolism, including medicines and diet, both. But we need a better, I would say, resource for discussing how do we achieve that. That is the most important part, and especially for Indian patient, as Edwina said, that this patient was not ready to use coconut. And I remember cases from Kerala where they somehow that they have impression that coconut oil is like amrit, and it is only medium chain. And a patient with VL-CAT was treated with coconut oil alone. So then I had to insist, no, we need MCT oil and not just coconut oil. And slowly we reduced coconut oil, and we saw improvement in the fatty acid levels. So this kind of, I would say, resources needed, but it will be probably a joint venture, dietitian with a clinician. It cannot be only clinician or only dietitian.
Yes, doctor. So what I understand you're saying is that we need this information. And I think currently we can lean on people like you and Edwina and several other dietitians who are actually practicing. So we learn together and maybe help each other.
Yeah, I think
Thank
Dr. Sheetal is there in the audience. Like
Yes.
senior dietitians, they can really help us because they have much more experience, senior ones, how to handle. The parents have hundreds of questions. As I said, somebody came to me that 23 grams of banana, but which banana to give? So as a clinician, I don't know whether the yellow one, green one, red one, which one to use. Is there any real difference? We don't
Yes.
know. So I think there are some silly questions, but they are practical. The parents were like totally taken aback. Okay, 23 grams. How do I give?
The next question, doctor, is stem cell therapy useful? Is there any research for the beneficial effects in IEM?
Okay. Yeah. So see, stem cell is a very big topic by itself. And we need to understand stem cell will work only if you have some good neurological status in the child. If child is, say, totally retarded, or for any reason child is totally, say, something like a bedridden or having recurrent seizures, doing stem cell therapy probably will not be a very good idea because it will not work for a good outcome. Theoretically, yes, you can do. Say, suppose I take an example of MPS 1. MPS 1 will have some cases have a lot of neurological problem, some are mild. So in the mild cases, I would say yes, please go ahead. But if it is very severe, then it may not work. So earlier the better if you want to do. And if you want to do, child should be in a good shape to do. So I'll just give one example that in US, they started doing newborn screening for X-linked adrenoleukodystrophy and Krabbe disease. And the idea was you pick up early and within 3 weeks, you do HSCT, stem cell transplant. And if you do that, you can cure this child permanently. Unfortunately, what happens is we see cases like this. They come to our clinic at the age of 8 or 10 years. Just last week, we saw one case who was 18 years. Now, in such cases, doing stem cell is not going to work. So it is a good therapy. It's like a weapon. You should know how to use, when to use. So it is a good option, not for all the cases. There are some limitations, but anything which is, say, possible where you can do stem cell, and there are standard lists like, say, for example, severe combined immune deficiency or thalassemia, you have very good results. But if you have something like osteopetrosis or some very severely retarded child with, say, uh, any neurological condition, for example, Krabbe, doing it late probably will not help. So it is a good therapy, yes. You should think about it. And I do recommend for my patients.
Okay, doctor. Thank you. I think I will ask a couple of questions for Ms. Edwina, and then I will come back to you if time permits. Edwina, one question for you is, are there any special products now available in India? How can caregivers actually obtain these products at low cost?
Yes, ma'am. There are two companies. One is Pristine and SP. Both are available at low cost, in fact. Similar to all the infant formulas, the cost is hardly 1,000 and 1,500. Within that range, they can avail it. So they have also come up with some low protein cookies, and there is another company who has also shown interest because the cases are increasing. There are more companies who are showing interest to bring in IEM products in the market. So probably way forward, we will be able to get more response from these companies too. And as sir mentioned, taste is very bad, and we try to give it through juices or even through sago porridge to mask the bitter odor, and sometimes the color changes also.
Yeah.
And one product even curdles if you mix it with fruit juice. So off odor is definitely there, and we feel very bad when kids don't accept. So maybe uh, we are looking for better products in future.
Okay, thank you. How do you actually, there is one more question is, I think it's particular relevance to one of the cases, the case you presented. Don't you feel more protein was important in order to improve the protein and albumin levels? I think-
Definitely, it is necessary. We do it gradually. because it was extremely low protein intake. It was hardly 2 grams. So we do it gradually till the baby tolerates, and in phases we do it. So that's a good question. Thank you.
Thank you. And maybe the last question that I will ask both of you together. What is the biggest challenge you face in IAM in India? I mean, what is the thing that you really wish is something that you can overcome in order to take care of these children?
So to answer this, I think challenges are at every step. First is diagnosis. The pediatricians, clinicians, any like even for adults, we should have high index of suspicion. And unfortunately, here we have this kind of mentality: oh, IMs are rare. We never learned during our undergraduate periods, and it is something for only specialists. No, everyone will face. As I say, if you have not seen metabolic disorder, you have not seen enough patients. So if you have good number of patients, definitely there are metabolic patients, and these are for lifelong. Like metabolic patients are not there for cough cold. It's a lifetime treatment. I have patients who are now 28 years. I am a pediatrician. I should not see more than 18 years, but I have to see because adult physicians are not ready to accept them. That is the problem. So recognition is important. Of course, availability of whatever products, medicines, diets, and there are so many other things, gene therapies and ERT, transplants. Now, Government of India is taking some interest into what we say rare disease policy, and some of the products, some of the therapies are being made available slowly. The process is slow. Not everybody gets it, but at least it has started. So that is a good thing. So this kind of availability is another big challenge. And third challenge, as we used to face, was a dietitian, because I don't have time to sit and calculate. Though I can open a book, do calculations of how much phenylalanine or how much lysine child is taking. But I would need somebody who is doing it properly and then talking to patient, because they need lot of queries. They have a lot of queries. They want to ask so many things, that white rice or brown rice or this or that. Clinicians don't know. So we need a very good team of dietitian. And I'm lucky I have at least 3 or 4 good dietitians at different cities, and they are doing extremely good work. Edwina is there, Madhvi is there. There are so many people. So this is a real good challenge, I would say. A good trained dietitian is absolutely a must. It's a day-to-day need. It's not once in 3 months. It's day-to-day, really.
Okay, Dr. Dad. Thank you, Dr. Jalan. And what I understand you're saying is there are several challenges, but there is hope. We can work together as an interdisciplinary team and move forward and improve, the condition of all the IAM cases in our country. And thank you very much. And the audience also has been really spectacular. We have actually, like Edwina said, overcrossed our capacity 100, and each time only one drops. They're like eagerly somebody is waiting to join. So that is a true testimony to both of you that there was clear eagerness and interest in what you were presenting. Thank you. And we are planning several other sessions. We will keep you posted. I would like to now hand over the mic to the co-convener of the Bangalore Chapter Nutrition Society of India, Dr. Lakshmi Jitendra, to give the vote of thanks. Thank you.
Good evening, everyone. Thank you, Rebecca. It's my privilege to stand here to express our collective gratitude on behalf of NSI Bangalore chapter. First of all, I thank Almighty for making this program a grand success. On behalf of NSI Bangalore chapter, I express my sincere gratitude to our respected speaker, Dr. Anil B. Jalan, founder of Nirman Navi Mumbai, for accepting our invitation and sharing the wisdom on dietary management of various cases of inborn errors of metabolism, especially the cases of organic acidemias and other special case scenarios with a practical background. I'm sure the practicing dietitians had a great advantage from the session through these case scenarios. I also extend my thanks to Ms. Edwina Raj, Chief Dietitian, Aster CMI Hospital, Bangalore, who has taken a lead for arranging the best speaker for today's session and sharing your knowledge about the disease through a case study presentation. Special thanks to Dr. Sharad Gopalan, who joined in the beginning of our session. My sincere gratitude to the headquarters of Nutrition Society of India, NI in Hyderabad, and the Executive Committee of Bangalore chapter for all the support rendered for the event. Thanks to Deepa for anchoring today's session, and a big thank you to all the participants for their presence who made this event a grand success. Thank you, everyone. Thanks, Rebecca. Have a nice evening.
Thank
Thank
you.
you.
Thank you so much.
Thank you very much.
I think we
There's
can
a
have a
feedback
photo. Yeah, we can have a photo, Dr. Rebecca. I think they can all switch on the video and we can have a photo. Yeah. Just one screenshot.
Yeah. Thank you. And
Uh,
also just a reminder before we go about the feedback form, kindly fill in the
Yes.
feedback form.
Participants, kindly switch on their video so that we can have a snapshot. Yeah. Whoever is there, I have clicked. Deepa, you can also click.
The participants won't come?
I think it's across the time, no?
Okay.
No participants. They can.
They're just joining now, I think.
Yeah, joining.
Mm. Mm.
Yes, Rebecca, I think most of them have
I
captured.
think we are done. Thank you so much.
Yes.
Thank you so
Thank
much
you so
once again.
much. Yeah.
Bye. Bye, Dr.
Bye.
Dallan. And
Bye.
Edwina,
Thank you very
bye.
much.
Thank you so much.